ladies and gentlemen. My name is Chun. Actually, I'm a consultant physician from Hong Kong. Today, it is my great honor to be here to share with you optimal monitoring of the long-acting antiretrovirals in routine practice.
Antiretrovirals in routine practice. 我没有任何的申报。
I don't have any further disclosure. Please allow me to give the introduction. You know that the virally controlled HIV patient going to be benefited from ART. At my center, there are a few reasons why the patient going to take ART. First of all, the patient may see some side effect. They may have the drug burden, or they started to have the complications or the worsening factors. For example, the chronic rhinitis, or if the patient was still adopting the traditional protocols with high toxicities and risks. So we can actually change the treatment to oral treatment or the injections. Where for ART, we now have carboplatin plus rilpivirine. Both are very potent drugs. And we need to actually evaluate the patient and also understand the long-term drug-related AEs. The ART we recommended are actually those patients who would like to actually have a good virus suppression. So as we are handpicking the right population to switch them to the ART, we need to know the drug really works for the patient. First of all, the patient need to be qualified of using that. They need to meet in the following conditions. First of all, they need to have the oral suppression, and they also need to be treated with a stable oral dosage for at least 6 to 12 months. And also, they are not having the tolerability mutations due to the carboplatin or any of the rilpivirine, and also making sure the patient don't have any of the virus control failures in the past. And more importantly, the patient, they are happy and be able to go to the clinics for the intramuscular injection. It needs to be performed by the professional healthcare caregivers. It's not allowed to have the at-home injection by the patient themselves. So as we are converting the patient from one drug to another, we need to also monitor the AE. So one thing we need to pay attention to is indeed the drug safety. As we are monitoring the AE, actually a commonly seen AE, as far as I believe, it's around 10% of the patient who are going to have the commonly seen AE. For example, injection site reactions, and also headache and fever. Especially you can see some patients being treated at my center, and it's commonly for them to have the injection site reaction, where there are also some other common AEs, for example, depressions and mood disorders, and also abdominal pains, insomnia, and fatigue, dizziness, dry mouth, vomiting, and also loss of the appetite and increased physical activity. But generally speaking, when we're switching the patient from one treatment to another, we will surely be able to discuss with the patient regarding the possible AEs. Generally speaking, some of the AEs we saw are still the injection site reaction, but for sure, many of the patients, they are just injecting on both sides of the buttons, just one drug on each side. Then every time when they come up to the clinic, our nurses will also help to check whether the patient indeed have any injection site reaction, and then to make the record, and it's been documented. So after the first injection, we're going to observe the patient for 10 minutes. If the patient started to have the post-injection reaction, then for sure we're going to follow the clinical practice and the guidelines to do the monitoring and the treatment. Later, I'm going to report to you some of the cases from my center. You know that in the following case I'm going to introduce, we don't have too much patient suffered from injection site reaction. Generally speaking, they're just having the injection site pain. And I also would like to say that injection site pain going to be decreased as time goes on. In this clinical trial, we call it Atlas trial. You see, generally speaking, for the patients, at the very beginning, around 60 to 80% of them will see the injection site pain. But less of them are actually reaching the level that they need to withdraw from the trial. Where at the same time, you can see as time goes on, and we have a less patient who's going to be suffered from an injection site reaction. Besides those AE, we are also going to keep an eye on those patients who used to have the chronic hepatitis or the patient who actually have increased the transmission enzymes. We need to indeed keep an eye on the transmission enzyme because it's going to be related to the hepatic toxicities of using the long-term carboplatin and rilpivirine. Generally speaking, after the long-term treatment, you need to monitor the liver function every 4 weeks, and then once every 3 months. If the transmission enzyme levels being stabilized, then the interval of each monitoring could be lasted for 6 months. Generally speaking, if the patient have a stable condition, and if they are compliant patient, then you can allow the patient to go back for the routine blood test every 6 months.
Besides for the liver function, and so that we will monitoring the patients like viral load monitorings, and then after the patient have switched to this like carboplatin and also rilpivirine, with or without for those oral lead-in, it is recommended to monitor for the patient's viral load usually every 4 weeks for the first 3 months until it is clear that for the viral load is still suppressed, and then the patient is able to adhere to treatment and then go to the clinic regularly for the injections. And thereafter, reduce monitoring frequency to every 3 to 6 months. If the viral load is more than 200 copies, it is recommended to repeat for the viral load and check for this like for the patients like a genotype for its a resistant assay. And this is actually for the patient treatment process in our center. And after switching for the treatment, and then, like I said before, we will recommend the patient to take oral like medications for like 4 weeks first. This is optional so that the patient will decide. So the 90% of the patient will take these oral medications first, and then to see whether there will be any like a serious adverse event. And then after for this oral medication, we will prescribe the 3 doses of the injectable medication. And then will be like every 2 months for injection visit and given by nurse. And then also that for the patient will also visit the doctor every 6 months for this like a blood and also treatment monitoring, so that the patient will not come back to the clinic that often, and they will also have a like every 6 months like, visit with the doctor, but with a like a longer time of the consulting. Also, we are providing for the patient treatment manual, like instructions. So we can see that before the treatment, we prepared this kind of patient education material for them, and let them decide whether they would like to switch. And at last, I would like to share with you the study that we have been like proposed in the EACS 2024 meeting. And this is a like a real world use for the long-acting like cabotegravir and rilpivirine in a HIV center in Hong Kong, which is in our center. And in 2022 June, And for this like long-acting like cabotegravir and also ribavirin, and is introduced in Hong Kong. And between July 1st, 2022 to the 30th of June 2023, and a total of 18 infected patient using cabotegravir and also ribavirin long-acting regimen were enrolled in the single center study in Hong Kong, all included infected for like all of these like subject enrolled are like Chinese like descent, including 17 males and 1 female with a median age of 37. You can see for the median duration of the infection is 7 years, quite long. And this is also one of the reason for like switching for the medications, avoiding for like a daily medication. And before switching to like cabotegravir and ribavirin, 83% of the patient used a 3-drug medication, which is a like a just a 3-drug combination regimen, and 17% of the patient use a just a 2-drug regimen. 88% of the patient were on a antiviral regimen based on INSTI, and 12% on the antiviral regimen based on the NRTIs. Among the patient with a virus load result after changing for the medication or switching for the medication, 71% of the latest viral load results were lower than 12.1, and 29% of them were lower than 30. As of October 2023, all of the subjects are still using this long-acting cabotegravir with like ribavirin, and for the median follow-up time is 5 months. So summarize for my talk is that before we decided that the patient needs to starting the treatment of the long-acting LT treatment, we need to identify whether the patient is eligible, is right to use this treatment just regimen. We need to confirm for the patient's like a criteria, and to just like understand whether the patient is feasible to come back in every 2 months to get the injection. And then we need to monitoring for their adverse event and also for the adverse reaction, especially for the injection site reaction. And at the end, we will also focusing on the monitoring for the patient's liver functions and for their viral load. And in our center, we do have some patient for their viral load or just like keep in the status of like a suppressed. So this is all from me. Thank you very much for your listening. And if you have any time, you can always contact me.